Hello everyone, this is Dr. Demito and I have put together a review of the last 4 weeks of class content for Pharm 2. If you have any questions or concerns, please feel free to reach out to me at any time. I always like to start my reviews with a disclaimer that this is not intended to be your exclusive method of studying for your upcoming final. This is used as an adjunct um, to help to guide your studying and also give you a greater understanding of the last 4 weeks of content. Now, some of the material that I cover may be on the exam. Other material I may include because I find that these will be pearls to add to your clinical practice as you move closer to actually starting your practicum piece. So again, don't use this as your exclusive method of study. Okay, let's go ahead and get started. Okay, our first topic today covers depression, and it's really important for nurse practitioners to have a good understanding of depression. Now, I'm finding many nurse practitioners are entering the field of psychiatric care. They even have a specialty as a psychiatric nurse practitioner, which there's a great need because the mental health system in this country is definitely in need of some help. And when I think of nurse practitioners, what a perfect role they can play in helping this population of people. Depression often presents itself with feelings of hopeless and anxiety. Um, Sometimes the symptoms are symptomatic, like headaches, uh, sleeplessness, and it's important to build good working relationships with your patients. So, especially if you're in primary care, you build rapport with your patient or build a rapport with your patient that allows them the ability to connect with you. So they're more likely to disclose things to you. They build a level of trust. And if patients begin to discuss things that they're feeling hopeless or they've been experiencing anxiety or headaches, begin to talk to them, have a conversation. Are they drinking more alcohol than usual? Have they had any suicidal ideation? If you deem it necessary to begin treatment with pharmacologic agents, there are many of them out there. Sometimes we refer to psychiatrists to prescribe medications, but there are certain considerations that as a nurse practitioner we need to think of when we are dispensing antidepressants to our populations. For example, serotonin uptake inhibitors. Um, Sometimes if they're on an SSRI, you may need to consider giving other medications, especially if they have an ongoing poor appetite and insomnia. So if we have a patient on an SSRI and they have continued issues with appetite, inability to sleep, we're going to keep them on the SSRI because SSRIs are great for depression and anxiety, but we're going to add something to it. We're going to add mirtazapine. Mirtazapine is going to help with that appetite and insomnia, so it's going to help them go to sleep. Another medication, Paxil, you may have heard of this. Paxil, I'm not a super fan of Paxil. It's got a lot of nasty side effects. It can cause weight gain and sexual dysfunction, and it's also, you have to wean patients off of it, and it can take a considerable amount of time to wean them off. But if they're having the weight gain and sexual dysfunction, you can add bupropion, which is Buspar. That will help too. Oh wait, bupropion. I'm doing that wrong. I think that is Wellbutrin. And it's important to know the generic names because when you take your certification exam down the road, um, the medications are all going to be in the generic name. Now, we want to advise our patients about the side effects of these medications, and they may be unique to other populations. Prozac, fluoxetine, they have different side effects. So you want to have this conversation with your patients. And also, you need to consider the age of patients too. Teenagers have a greater risk of having untoward side effects from antidepressants. So you're going to want to see those teenagers weekly because they have a greater risk of suicidal ideation when they begin taking antidepressants. Fluoxetine can cause an increase in nausea, decrease in appetite early on in the treatment. It's not something that would cause me to take the patient off and start something else because it takes a bit of time. And the geriatric population, often they're losing loved ones. They may have lost a partner that's been their partner for decades, and this may cause difficulty sleeping. So mirtazapine, that's a mild benzodiazepine, works really well in the geriatric population for sleeping. If the patient presents with depression but also has chronic pain, like patients with fibromyalgia, we'll recommend the use of Cymbalta because Cymbalta has an effect. It actually helps with pain as well as depression. Okay, anxiety. Anxiety and depression can go together. They don't always go together though, but they can. This is just a pearl that if a patient is experiencing anxiety, I typically will start them on a low SSRI like Zoloft. And if they also have depression, then I'm going to increase that dose. So 50 milligrams a day is the treatment for anxiety. If they're suffering from depression, I'm going to bump it to 100. And that'll cover both the depression and the anxiety. Now, as I had said before in the last slide, in the elderly population, they may have anxiety and it's going to hit them primarily when they're trying to go to sleep at night. So mirtazapine is a good choice for them to use. In the adult population with anxiety who can't sleep, alprazolam works good. I also, if a patient is experiencing situational anxiety, so perhaps they have a fear of public speaking or they're going through a divorce, cognitive behavioral therapy can work really well with situational anxiety. Okay, anxiety and poor sleep due to traumatic events, fluoxetine works really well with. So, for example, if someone has been in a horrible accident of some, and they are not able to sleep because of these traumatic events, we may want to consider using fluoxetine on those patients. Okay, our next topic is sleep dysfunction, and the inability to sleep can be caused by many different things, and it can also be sleep dysfunction can be inability to go to sleep or waking up in the middle of the night and not being able to go back to sleep, sleepiness during the daytime. All of those things are considered sleep dysfunction. So if we have a condition where we can't sleep because we've got racing thoughts, you might want to consider using buspirone, that's Buspar, and that can help. It helps to quiet that racing. We also want to do a complete physical exam to rule out other causes of this sleep dysfunction. We need to consider sleep apnea. Obesity can also be related to sleep dysfunction, but thyroid issues. So let's do a complete physical with blood work to make sure that we don't have any health issues contributing to the sleep dysfunction. We're also, as a first line, we're going to evaluate their routine. So what do you normally do? It's recommended that people actually stop using, I think they call it blue light. So, like, no computers, phones, at least 30 minutes before they go to bed at night. Sleep hygiene, they call it. Also, you want to limit caffeine. How much caffeine do you drink? And there's also a condition. People get up in the middle of the night, they go to the bathroom, they come back to bed, and now they can't go to sleep. Well, there is a medication called Zolpamist, which is actually a derivative of Ambien, but it's short acting. It doesn't have the short the because Ambien, they'll tell you if you can't sleep for 8 hours, don't take it because the effects will last. This is rapid onset and short. It doesn't last a long time, so you won't have to get into, worry about having 8 hours to sleep because that could be problematic. Schizophrenia. Now, most nurse practitioners will not be working with schizophrenia as a diagnosis unless you're in this field, but you may have patients, if you're in primary care, who experience schizophrenia because people who have mental illness still get sick, and their psychiatrist isn't going to treat them for strep throat or urinary tract infection or any of those things. So you still may have patients that um, experience schizophrenia. Schizophrenia is a condition that typically strikes young people, so around in their 20s, about college age. And it often the first sign is disorganized thoughts, disorganized thinking. Parents will often see a change in behavior where their children are exhibiting major changes in behavior. They may now not take care of them. They may have poor hygiene. They may not be dressing well. They may speak and their words don't make any sense. So then they may take the child in for an examination, or they may be great performers in school and all of a sudden they're failing everything. And sometimes the parents may be suspicious that it's drug related, and sometimes it is, but other times it's mental illness. And schizophrenia is one of those diseases. There's a familial tendency, so it does run in families. The problems with the treatment for schizophrenia is that many of the medications have multiple side effects. Mellaril can cause difficulty with small tasks. So if you have a patient who's on that, you might want to consider using risperidone instead. And also, if we are in primary care and we have a parent bring their young adult in for a consultation, and the parent's telling us that something is going on, they suspect that there may be something going on mentally, they have a family history of mental illness, or they have these disorganized thoughts, we as nurse practitioners may not initiate care. We may refer out to psychiatrists for consult, but typically what I would do as a provider would be order things like a CBC, an ECG, a UA. I'd have all of those things ready and the results done so that when the psychiatrist is going to begin dispensing medication, that they have those labs in front of them because those labs are important. Now, I had said before that a lot of these medications, antipsychotic medications, have side effects that are just nasty. And that's one of the problems with schizophrenia, is that the patients don't want to take the medication because it may make them exhausted. All they want to do is sleep. It can also cause things. They run the risk of tardive dyskinesia, which is a repetitive motion. It's a side effect of medication, and it's permanent. It can cause weight gain. Now, there are some things that we can do. If we see that we've got a schizophrenic with weight gain, maybe a history of diabetes, We may want to consider a drug like geodone because that will cause fewer side effects related to weight gain. If they are obese, we can add Abilify to the treatment plan, and that will help with their obesity. With some of these drugs like Zyprexa, we'll start with a low dose and wait and see. So start with a low dose. If the patient's tolerating it well and it has helped their symptoms a little bit, then we're going to increase the dose. So this is a very specialized diagnosis, and if you are planning on delving into this field, it's important to have a really good understanding of the medications and side effects and all of the different things that we can do to help our patients who are experiencing the symptoms of schizophrenia. Now, I decided to put this slide in, Clozaril. This is one of the drugs we use if we have a patient who is, it's an antipsychotic medication, but we use it in dementia. So, because there are a lot of uses. If we have a dementia patient who is experiencing hostility and combativeness, we can add this to their treatment regimen. The problem with this drug is that it increases the risk of heart disease and stroke, so we're going to watch CBC with DIF on these patients. Alcohol. This is such a troubling condition, alcoholism. Alcohol's very addictive, hard to get off, and it's legal. So it's a legal drug, and that compounds our issues. When we are having conversations with patients and we're doing that initial interview when patients are joining our practice, we want to have a conversation with them about alcohol and their alcohol intake. Now, sometimes when we're having this conversation with them, I find patients have the tendency to underestimate. Sometimes I'm surprised and patients tell me they drink this enormous amount of alcohol every week, and I'm surprised that they admitted to it. I'm glad they did, but sometimes it surprises me. But many times they underreport because there's a stigma attached with alcoholism. So I like to get as specific as possible. If a patient tells me I drink 2 glasses of wine with dinner every night, I would like to know, is that a 6-ounce glass? Because it could be an iced tea tumbler. So 2 glasses, that's a subjective number. I like to try to keep things objective when I'm talking about things like this. Now, there are some drugs out there that can help with alcoholism. Acamprosate, this is used to help alcohol dependence, but you need to keep a close eye on their renal function because those who abuse alcohol have the tendency to have some renal disease, and we want them to have functioning kidneys if we're going to prescribe this. There's another drug called disulfiram, which we can prescribe to patients, and if these patients drink alcohol, it will cause awful side effects, nausea, vomiting, dizziness. So this is more of this is a drug we give to patients who are having difficulty abstaining from alcohol, but it's really important that they do abstain from alcohol because the side effects are awful. We want to keep an eye on our alcoholic patients' liver enzymes, and if we're concerned about them going through withdrawal, of course we would consider withdrawal at an inpatient facility, and we can expect those patients to be on lorazepam to reduce the occurrence of seizures. Additionally, patients who abuse alcohol have the tendency to be low in B vitamins, so we want to make sure they've got enough thiamine in their system. So it's good to ensure they're taking a supplement. Now, opioids. This is hot news a hot topic in the news these days, and a patient can become addicted to opioids after 5 days of treatment. So we're really trying to limit the amount of medications we're sending our post-operative patients home on. Gosh, I can remember, 10 years ago, we would send patients home with a month's supply of OxyContin, and now we might only give them 7 days worth or less, maybe 3 days worth. I'm finding that my daughter works in an orthopedic unit, and they are using more non-narcotic medications for pain than they used to. We need to, as providers, I know I work in acute care, we keep Narcan in the office in the event someone comes in and we're concerned about an opioid overdose. And now police officers carry it, first responders carry it. Patients who are experiencing an overdose typically can exhibit symptoms of disorientation. And if they're cognizant, we can ask them about narcotic use. Have you taken anything? We want to consider that right from the get-go so that we can administer Narcan as quickly as possible. It automatically reverses the effect of the opioid, but you need to consider it's not the cure. It only lasts a short time, so we can't give them a dose of Narcan and they wake up and say, okay, go about your day. They have to be sent to the emergency department via ambulance and watched, because Narcan only lasts a short period of time, and they often will need, if they've taken a large amount of opioids, need multiple doses of Narcan. Oral contraception. Okay. Lot of considerations with oral contraceptives, and you'll need this information when you get into your women's health section for sure. Now, different considerations that we want to talk to our patients about. For example, if a patient is starting oral contraception and they have never been on it before, we're going to start it, and then they need to use condoms for the first 7 days because it takes time to build up in your system. In teaching, we want to tell our patients it's best to take that pill every day at the same time of every day. If you miss a pill, you're going to double up the next day. If you miss 3 days of pills, you need to begin a new pack. Take a Plan B pill if you're concerned about pregnancy, and use condoms for 7 days. So it's like starting all over again. Some women have difficulty remembering to take the pill, and there are other options out there for them. There is the vaginal ring. But if they're going to switch from the pill to the vaginal ring, they have to make that switch within 7 days, or else they have to start all over again with the 7 days of using condoms and worrying about pregnancy. If it's the first time that they are taking oral contraceptives, or if they are approaching menopause, we're usually going to we want to use a low estrogen if we can, low estrogen contraception. And sometimes they can cause a little bit of headache. Any oral contraception can cause headache, but the low estrogen has a decrease in the incidence of headaches. If we have a patient who is on birth control but intends on having a pregnancy within a year or two, it's advisable to have them take a folic acid supplement daily with their oral contraceptive, because that's a good thing to do to keep the folic acid level at a good level when they're considering pregnancy. I'm trying to think too, when you're looking at oral contraception, if the patient has a history of blood clots or any risk factors for blood clots, they have to take a progestin only. Progestin only oral contraception is what they have to take, because it's the estrogen that promotes blood clots. Osteoporosis. We want to, as providers, advise our patients some of the important things they can do to reduce the risk of osteoporosis. Again, this has a familial tendency to it. If they're we want to start them on calcium early. I advise my patients to start taking this calcium supplement at age 30 because you really start to begin to lose bone mass then. Weight-bearing exercise is also important. Limiting caffeine. If we are considering using a supplement, not a supplement, but if we are considering using a medication like Fosamax or one of those other medications for those who have osteoporosis, we want to consider using a medication that is not hormonal in nature if the patient has a history of cancer. Exogenous testosterone. You hear this on TV all the time. I think I do. Low T, and they claim to have all these products that will increase the testosterone in men. And I don't know if those sorts of things work or not that you buy over the counter, but I do know that some men do actually have lower than normal levels of testosterone. And exogenous testosterone can actually help improve their fertility. We do need to keep a closer eye on their blood glucose levels because they can cause elevation of blood sugars, but it can improve fertility, and also there are a lot of benefits if you have low T. That supplement will make you feel a lot better. Hormone replacement therapy. Now, probably 10 or 15 years ago, we just about eliminated hormone replacement therapy in practice, but we are now reintroducing it because we found that some of the studies that negated their use were really their population wasn't well thought out. Now, if a patient has a hysterectomy with hot flashes, we want to use an estrogen-only hormone replacement. We might need to adjust the dose. And we want to ensure that there's no family history of breast cancer. So if we're considering a hormone replacement, patient needs to have a negative mammogram before consideration, and then ensure that they're getting their regular mammograms. Breast cancer. Now, of course, if we're worried about a patient having breast cancer, we're going to send them off to a specialist, and they would go through their treatment with an oncologist. But again, patients with breast cancer, or patients who have had a history of breast cancer, will seek us out for treatment for health disorders, and there are certain things that we may see. If the patient has an estrogen receptive tumor, they may be on medication to suppress that estrogen. Now, estrogen is released from the ovaries, but it's also released in small amounts by other glands too, like the adrenal glands. So medications, aromatase inhibitors, it doesn't inhibit estrogen from the ovaries, but it inhibits it from other glands, like the adrenal glands. Arimidex is used in estrogen tumors. And some medications, some estrogen inhibitors, the patient may say, if they're trying to reduce the tumor size before they excise, they may be on some of these medications like Tormifin, and the patient may think that the tumor's gotten larger, but it'll go down. Now, I see a lot of patients on tamoxifen, but actually the aromatase inhibitors work well in postmenopausal patients especially. If they're on tamoxifen, we've got to check their liver enzymes frequently and CBCs. And I didn't know this until I was doing research for this lecture today, that patients with breast cancer should take vitamin C supplement daily. Okay, immunizations. All right, we get a lot of questions from our parents on immunizations related to their children. But immunizations is a lifelong process, and I think that especially in the adult population, they figure once they go to school, they're done with college, they may forget that they need a tetanus shot every 10 years, or did you get your flu shot? And then at the age of 50, we're looking at it's not the elderly population, but as we age, we need to consider PPV 13 and 23, flu exams every year, and a Tdap every 10. With children, they generally start their immunizations in the hospital. Their first immunization is a hepatitis B. They usually will get that in the hospital. Let's see. A few things to consider with immunizations and children, that if you have a patient who presents to your clinic for a pre-kindergarten exam and they don't have an immunization record, the state of Illinois does not have a good database. There are some states out there that every time an immunization is given in a physician's office, it's recorded in this statewide database. So if they're new to my practice, I can go into the database and I can see, oh, you're up to date with your immunizations. But unfortunately, in the state of Illinois, we don't have that option. They're working on it, but the state of Illinois is really, really slow. So if we have a patient presenting with pre-kindergarten exam and no vaccine record, we need to give them a DTaP. Now that's different than a Tdap. Tdap can't be given to children under the age of 7. So we want to give them a DTaP, an MMR, a Varivax, which is chickenpox, hepatitis A and B, and then the polio, IPV. Some people think that if children are sick, they can't get their immunizations. And yeah, if they really have a raging fever and strep throat, I'm probably going to hold off on that. But if they have a cold, you can still go ahead and administer the vaccines. Also, I'm finding that some parents would, because they do, sometimes they get, gosh, like 5 shots, although the pharmaceutical companies are doing a good job of combining vaccines into fewer injections. But some parents feel more comfortable spreading out the vaccines, and they can certainly do that, but they have to consider that the child is not going to have full immunity until they've gotten all the doses of the vaccine. So if we're spreading that out, it's increasing the child's risk of developing that disease. Now, when you give a child a vaccine, it isn't going to affect others. So, for example, when you're pregnant, you can't receive live vaccines. So you couldn't get a chickenpox vaccine or an MMR because those are live vaccines. And when you're pregnant, you can't have live vaccines. But if I'm pregnant, can I administer a live vaccine to my child? Yes, you can. It won't affect you and it won't affect others. Now, when children get a vaccine, it's normal for them to have an immune response. When you have an immune response, it's not uncommon to get a little bit of a low-grade fever, feel kind of achy and crummy for a day or two, and that's about it. You can treat that with Tylenol or ibuprofen, and they'll be fine in a day or two. All right, obesity. All right, and this is a candid conversation we have to have with our patients, and I pair with my patients because this is something I've struggled with myself. So I work with my patients and advise them what's worked for me, what hasn't worked for me. But on that first visit, we're going to discuss the long and short-term goals, and we'll discuss the options for them. What's out there? Now, we often will start with something like phentermine. Phentermine is an appetite suppressant, and it works pretty good, but it doesn't last a long time. The effect of it wears off over time. So once it loses its effectiveness, then you need to go to something else. Orlistat. You can see this. You can buy this over the counter. It's called Ally. This is another one that benefits are greatest in the first few months of using it. It blocks the absorption of fat. So it does have some um, unfavorable side effects. So these patients can have frequent greasy stools and leakage during the day. So I've never taken it. I haven't had a patient who's taken it, so I don't know how um, disruptive those symptoms are. Um, there are other drugs out there too that have been approved for the treatment of obesity, like Vyvanse. Vyvanse was just approved for the treatment of obesity. Smoking cessation. This is a topic you want to discuss with your patients in a non-judgmental manner, that's for sure, because they know they shouldn't be smoking. They know that there are going to be long-term effects. So remember, if you're in primary care, you're building partnerships and relationships of trust with your patients, so that you can have open and honest conversations with your patients about smoking. If you have a patient that's smoking and they deny it, of course, you know you can smell it on them if they're smoking. With adolescent patients, you want to discuss with them the negative side effects. And there are lots of treatments out there now. We have patches and nasal sprays and gum and lozenges. So with those nicotine replacements, you might have to adjust the doses. So if, for example, if you're quitting smoking and you are chewing on a piece of gum every so many hours for a month and it really helped, now next month we're going to lengthen the time between doses. Also, smoking when you're taking any of those supplements is going to increase your heart rate and blood pressure, so that's not a good thing. If you have a patient who's tried and failed repeatedly using nicotine replacement, you may want to try Chantix. I know a few people who have quit smoking successfully with that medication. Dietary changes with our patient. Now, vitamins don't replace healthy eating practices, so we need to advise our patients of healthy eating habits. We can refer them for a nutrition consult if they're having issues, but we need to advise them of making good choices. I'm not a big fan of any diet that eliminates food groups. I'm not a super great fan of Atkins because, of course, you can lose weight quickly on that, but you can also gain it back quickly once you stop the diet. So teaching your patients how to eat a balanced meal with portion control is important. Um, Sometimes patients think it's a good idea to use substitutes, and I'm terrible because I'm a huge Diet Coke drinker. So I love Diet Coke. Um, I hate salt substitutes, so that's never going to be an issue for me. But some salt substitutes and some sugar substitutes like xylitol, that can cause diarrhea, decreased blood pressure, and irregular heart rate. Supplements. Okay. Lots of supplements. Now, again, when you get to be in clinical and you're taking an interview, and I have to tell you, I think that learning good interview skills is one of the most important things you can learn. One of the most important skills a nurse practitioner needs to have. Um, you need to find out about their supplements, not just what kind of medications are you taking, but are you taking any vitamins, any supplements, any over-the-counter medication? I want to know what that is because they may have side effects. For example, ginkgo biloba, that can increase your risk of bleeding. So if you're on that and then you're taking warfarin also, that could be a problem. Um, Herbal supplements aren't regulated by the FDA because they aren't marked to treat or cure disease. So there isn't any regulating body identifying that when it says it's 50 milligrams in that capsule, that it is indeed 50 milligrams. Now, some supplement companies actually have their products go through a vigorous screening through an independent, gosh, what am I trying to say? An independent regulatory body, but some don't. And some of the supplements are wonderful. I take a whole bunch of medications every day. I take a whole bunch of vitamins. I take turmeric because I have inflammatory issues. So they can be good, but you need to understand the actions of all the ingredients. So when I decided that I was going to add supplements like turmeric to my regimen, I wanted to learn everything there was to know about that medication. My daughter, for example, she has interstitial cystitis, and she went to a doctor who also was a big believer in supplements, and he had her begin taking milk thistle, and it helped her immensely. It can also help in patients who have hepatotoxicity. Um, Vitamin D. Many patients in this state in particular are deficient in vitamin D. So I have all my patients take I check all the vitamin D levels and then have them take a supplement as indicated. As we age, we need a higher rate of vitamin B. And another thing too, think about echinacea. Echinacea is a supplement. It's an herbal supplement, and people use it to boost your immune system. Well, what block of patients do we not want to boost the immune system? People who have autoimmune disorders, like lupus, psoriasis, rheumatoid arthritis, because those patients, their immune system is already overactive. So we don't want to prescribe something that's going to make it even worse. So we want to avoid that. Over-the-counter medications, some considerations. 95% of all illness is viral, with the upper respiratory, runny nose, congestion, cough, and bronchitis. 95% of it is viral in nature. So I advise my patients to use over-the-counter medications to manage their symptoms. But I also advise them to only use medication to cover the symptoms that you actually have. So if you have a runny nose, why should you take a medicine that's going to help with congestion if you don't have congestion, if you don't have a cough? So you want to use single ingredients when possible. Also, read the packages. Get used to learning what ingredients are in packages. Because if I'm taking Dayquil has Tylenol in it or acetaminophen. So if I'm taking Dayquil, I'm not taking Tylenol too, because I run the risk of overdosing. Children are especially vulnerable to these things, so we don't want to potentially overdose patients. If the age and dose is not on the bottle, we need to list all the ingredients and identify exactly what the dose should be, or should they be taking it at all. All right, and I'm not quite sure why this topic is covered here, but it is, so let's look at it. Keratin deposits, and you can see this here. This is obviously Photoshop, but I got the idea of what they were talking about. These they look like little pimples, I guess you could say. Whoop, I passed it. But you want to give the patient beta carotene. Beta carotene will help. So I missed that slide, but that's okay. That's the conclusion of our presentation today. Not too bad, 45 minutes. Please let me know if you found this presentation helpful in your studies. And I wish you all the best of luck as you prepare for your final exam. Have a great evening.